Understanding skeletal dysplasias requires thinking about bone growth and development as a complex manufacturing process where even small errors in the production line can create profound effects throughout the entire skeletal system. Imagine trying to build a skyscraper using blueprints that contain subtle but critical errors. The resulting structure might be dramatically different from what was intended, even though the basic construction process followed the same steps. This analogy helps us grasp why skeletal dysplasias represent such a heterogeneous group of disorders. While they all affect bone growth and development, the specific errors in the genetic blueprints create over 450 distinct types, each with its own characteristic pattern of abnormalities. Think of this diversity as reflecting the complexity of normal bone development. When you consider all the different genes, proteins, and cellular processes involved in creating normal bones, it becomes clear why disruptions at different points can create so many different clinical presentations. The fact that many skeletal dysplasias can be diagnosed prenatally reflects advances in ultrasound technology that allow us to visualize developing bones during pregnancy. This early detection capability becomes particularly important for the more severe forms that might influence delivery planning or help families prepare for complex medical needs. However, the wide spectrum of severity means that some conditions are immediately life-threatening, while others create challenges that individuals can live with successfully for decades. This variability makes each case unique while still following recognizable patterns that help guide our clinical approach. Learning to classify skeletal dysplasias effectively requires understanding that we organize these conditions based on several different characteristics that each provide valuable clinical information. Think of this classification system as being similar to how we might organize a large library. We could arrange books by author, subject, publication date, or size, with each organizational method serving different purposes and revealing different insights about the collection. The location of shortening provides our first major classification approach, helping us understand which bones are most severely affected. Rhizomelic shortening affects the bones closest to the body's center, particularly the upper arms and thighs, creating a pattern where the limbs appear short, but the hands and feet remain relatively normal-sized. Picture this as the trunk of a tree being shortened while the branches remain proportional. Mesomelic shortening involves the middle segments like the forearms and lower legs, while acromelic shortening affects the bones farthest from the center, particularly the hands and feet. Understanding these patterns helps us narrow our diagnostic thinking because different genetic conditions tend to affect different bone segments preferentially. This geographical approach to bone involvement creates recognizable patterns that guide our evaluation and help us predict which studies might be most helpful. The lethality classification addresses the most immediate clinical concern, whether the condition is compatible with life or poses immediate threats to survival. This distinction helps us prioritize our interventions and guides our conversations with families about prognosis and treatment options. The timing of onset, whether prenatal or postnatal, influences both our diagnostic approach and our understanding of the condition's natural history. The anthropometric measurements we perform in babies with suspected skeletal dysplasias serve as our primary diagnostic tools, providing objective data that helps us distinguish between different conditions and monitor growth patterns over time. Think of these measurements as being similar to how an architect might survey a building to understand its proportions and identify any structural abnormalities. Each measurement provides a piece of the puzzle that helps us understand the overall pattern. Length and head circumference provide our baseline measurements, but their true value emerges when we compare them to each other and to normal growth patterns. Many skeletal dysplasias create characteristic ratios between body length and head size, with some conditions causing proportional shortening while others affect the limbs more than the head, creating babies who appear to have relatively large heads for their body size. The upper to lower segment ratio helps us understand whether the shortening affects the trunk, the legs, or both proportionally. To measure this ratio, we determine the upper segment by measuring from the top of the head to the top of the pubic bone, then calculate the lower segment by subtracting this measurement from the total body length. Normal ratios change with age, making age-specific reference values essential for accurate interpretation. Arm span measurements become particularly valuable because they often remain normal even when body length is significantly reduced, creating characteristic patterns that help differentiate between conditions. Chest circumference assumes critical importance because many skeletal dysplasias affect rib development, and thoracic insufficiency can become life-threatening in severe cases. The key insight involves understanding that plotting these measurements on condition-specific growth curves provides much more valuable information than simply comparing them to normal population curves. These specialized curves help us track whether a child's growth pattern follows the expected trajectory for their specific condition, enabling us to identify complications early and adjust treatment plans accordingly. When you encounter achondroplasia in your practice, you're seeing the most common skeletal dysplasia that affects living individuals, making it essential knowledge for any practitioner working with children. To help you understand why this condition deserves special attention, consider that while over 450 skeletal dysplasias exist, achondroplasia accounts for the majority of cases you'll actually encounter clinically. The fundamental concept to grasp is that achondroplasia represents a condition that's fully compatible with life, meaning affected individuals can live normal lifespans with appropriate medical management. This distinguishes it from many other skeletal dysplasias that create life-threatening complications. The incidence of 1 in 20,000 births makes it rare enough that many practitioners have limited experience, yet common enough that you'll likely encounter it during your career. Understanding the genetics helps explain the clinical patterns you'll observe. While achondroplasia follows autosomal dominant inheritance, meaning only one abnormal gene copy is needed to cause the condition, approximately 80% of cases result from new mutations rather than inheritance from affected parents. This high rate of new mutations occurs because the specific genetic change that causes achondroplasia happens spontaneously during reproductive cell formation, creating affected children born to parents of normal stature who had no previous family history of the condition. The clinical features of achondroplasia create a recognizable pattern that becomes unmistakable once you understand how the underlying genetic defect affects bone growth throughout the body. Think of this condition as affecting different bones in predictable ways, creating a constellation of findings that work together to produce the characteristic appearance. Rhizomelic shortening represents the hallmark finding, where the bones closest to the body's center become disproportionately shortened. Picture how this affects the overall body proportions. The upper arms and thighs become much shorter than normal, while the forearms, lower legs, hands, and feet maintain relatively normal lengths. This creates the characteristic appearance where the limbs appear short, but the hands reach only to the hips, rather than the mid-thigh level you'd expect in someone of normal stature. The large head with frontal bossing develops because achondroplasia affects the skull bones differently than the limb bones. The condition interferes with the normal growth of bones that form through cartilage replacement, but the skull grows through different mechanisms that remain largely unaffected. This creates the characteristic appearance of a relatively large head with prominent forehead development. Mid-face hypoplasia occurs because the bones of the middle portion of the face are affected by the same growth abnormalities that impact the limb bones. This creates a flattened appearance of the nose and cheeks that contributes to the recognizable facial features. The trident hand describes the characteristic spacing of the fingers, where the middle fingers spread apart, creating a three-pronged appearance reminiscent of a trident. Perhaps most importantly, normal intelligence remains completely intact, making this a condition that affects physical growth without impacting cognitive development. Understanding the specific challenges that affect infants with achondroplasia requires recognizing how the anatomical differences create unique medical needs during the first year of life. Think of these issues as the intersection between normal infant development and the altered anatomy that achondroplasia creates, producing complications that require specialized knowledge and monitoring. Hypotonia commonly affects infants with achondroplasia, creating muscle weakness that goes beyond what you might expect from their skeletal differences alone. This hypotonia results from the neurological effects of the condition, particularly the impact on spinal cord and brain stem function. Picture how this affects the baby's ability to achieve normal motor milestones. The combination of altered bone proportions and decreased muscle tone creates a double challenge for motor development. The delayed motor milestones occur predictably because babies with achondroplasia must overcome both their hypotonia and their altered body proportions to achieve skills like sitting, crawling, and walking. Think of this as learning to use a body with different mechanical advantages than what standard developmental timelines assume. Foramen magnum stenosis creates the most serious risk during infancy because the opening where the spinal cord enters the skull can become narrowed, potentially compressing vital neural structures. This anatomical problem explains why you must avoid unsupported sitting in these infants. The large head combined with hypotonia creates mechanical stresses that could worsen any existing compression. Thoracolumbar kyphosis develops because the altered spinal anatomy combined with hypotonia creates abnormal curvature patterns. Understanding these interconnected problems helps you appreciate why achondroplasia requires comprehensive, knowledgeable care rather than simply monitoring for growth. The monitoring requirements for infants with achondroplasia focus on detecting the potentially serious complications that can develop due to the altered anatomy and neurological vulnerabilities inherent in this condition. Think of this monitoring as being similar to watching a complex mechanical system where several components could fail in predictable ways, requiring vigilant surveillance to catch problems before they become emergencies. Head circumference monitoring assumes critical importance because hydrocephalus can develop when the altered skull anatomy interferes with normal cerebrospinal fluid circulation. Picture how the characteristic skull shape changes might affect the pathways that normally allow fluid to flow freely around the brain. When these pathways become compromised, fluid accumulates and creates increased pressure that can damage brain tissue if not recognized and treated promptly. The signs of spinal cord compression require your constant attention because the anatomical abnormalities can create pressure on the spinal cord at multiple levels. Look for the development of apnea, which suggests brainstem compression, worsening hypotonia that might indicate spinal cord pressure, or hyperreflexia that could signal upper motor neuron involvement. These signs represent a neurological emergency requiring immediate evaluation. Monitoring for the development of kyphosis becomes essential because the spinal curvature abnormalities can progress during growth and create additional compression risks. Think of this as watching for structural changes that could compound the existing anatomical vulnerabilities. The requirement to use achondroplasia-specific growth curves rather than standard growth charts ensures that you're tracking the baby's development appropriately for their condition. Standard curves would make every measurement appear abnormal, while condition-specific curves help you distinguish between expected growth patterns and true complications requiring intervention. Managing infants with achondroplasia requires understanding how their altered anatomy creates unique vulnerabilities that standard infant care practices might not address adequately. Think of this management approach as adapting normal infant care to accommodate the specific needs created by the skeletal and neurological differences inherent in this condition. The instruction to avoid soft carriers and unsupported sitting addresses the critical vulnerability created by foramen magnum stenosis combined with hypotonia. Picture how a soft carrier might allow the large, heavy head to flex forward onto the chest, potentially compressing the brainstem through the narrowed opening at the skull base. Similarly, unsupported sitting places the baby in a position where the head weight could create dangerous flexion forces on the vulnerable upper cervical spine. Physical therapy for core strengthening becomes essential because the hypotonia affects the muscles needed for postural control and motor development. Think of this intervention as providing the baby with enhanced muscular support to compensate for the neurological challenges while working within the constraints of their altered body proportions. Hydrocephalus monitoring requires systematic assessment because the condition can develop insidiously, with subtle changes in head growth or neurological function providing the only early warning signs. This monitoring involves not just measuring head circumference, but also observing for changes in feeding, sleep patterns, irritability, or developmental progress that might indicate increasing intracranial pressure. The decision to obtain MRI when neurological signs develop reflects the need for detailed anatomical information to guide treatment decisions. When you suspect spinal cord compression or hydrocephalus, imaging provides the definitive information needed to determine whether surgical intervention is necessary. Genetic counseling helps families understand the inheritance patterns, recurrence risks, and reproductive options available to them, providing essential information for family planning decisions. Understanding the genetics of achondroplasia provides crucial insights into why the condition develops, how it's inherited, and what families need to know about recurrence risks and reproductive planning. Think of this genetic knowledge as the foundation that explains all the clinical features we observe and guides our counseling about family planning and prognosis. The specific mutation involves the FGFR3 gene, with the most common change being a glycine to arginine substitution at position 380. To help you understand why this particular change is so significant, think of FGFR3 as a critical control mechanism that regulates how cartilage cells grow and divide during bone development. When this gene is mutated, it creates a protein that sends continuous stop-growing signals to developing cartilage, resulting in the shortened bones characteristic of achondroplasia. The paternal age effect represents a fascinating aspect of this condition's genetics, where advancing paternal age increases the risk of new mutations occurring. This happens because the cells that produce sperm continue dividing throughout a man's life, and each division creates opportunities for copying errors to occur. Think of this as similar to how a photocopier might produce more imperfect copies after running continuously for many hours. Understanding that the homozygous form is lethal becomes crucial for genetic counseling, particularly when two people with achondroplasia are considering having children together. When a baby inherits the mutated gene from both parents, the resulting double dose of the abnormal protein creates such severe skeletal abnormalities that the condition becomes incompatible with life. The availability of prenatal diagnosis through genetic testing provides families with reproductive options, while understanding recurrence risks helps them make informed decisions about family planning based on their specific circumstances and values. When you encounter Thanatophoric dysplasia, you're facing one of the most challenging situations in neonatal care, a condition whose very name means death-bearing and reflects the grave prognosis these babies face. Understanding this condition requires recognizing it as fundamentally different from achondroplasia, even though both involve skeletal abnormalities. To help you grasp the severity, think of Thanatophoric dysplasia as representing the extreme end of the skeletal dysplasia spectrum. While achondroplasia creates significant short stature but allows normal lifespan, thanatophoric dysplasia affects skeletal development so severely that it becomes incompatible with life. The condition stands as the most common lethal skeletal dysplasia, meaning you're more likely to encounter this than other fatal bone disorders. The severe limb shortening creates a dramatic appearance, where the arms and legs appear extraordinarily short compared to the trunk, far more pronounced than what you observe in achondroplasia. Picture the difference between shortening a building by removing one floor versus removing most of the floors. The proportional impact becomes immediately apparent. The narrow chest creates the life-threatening complication because the ribs cannot develop properly, resulting in a thoracic cavity too small to accommodate normal lung expansion. This chest restriction, combined with other anatomical abnormalities, creates the respiratory insufficiency that makes this condition lethal. Understanding that two distinct types exist helps you recognize that while both are fatal, they have slightly different clinical presentations and genetic causes, though this distinction doesn't change the fundamental prognosis or management approach. The clinical features of thanatophoric dysplasia create a constellation of findings that help you recognize this condition while understanding why it proves incompatible with life. Think of each feature as representing a different aspect of how severely disrupted bone and cartilage development affects the growing baby. The macrocephaly develops because the skull growth follows different mechanisms than limb bone growth, creating a disproportionately large head compared to the dramatically shortened body. This creates a striking appearance where the head size seems even more prominent against the background of the severely shortened limbs and trunk. The cloverleaf skull deformity, seen specifically in type 2 thanatophoric dysplasia, creates one of the most distinctive radiographic appearances in all of medicine. Picture how this skull shape gets its name. When viewed from above, the abnormal suture fusion creates a three-lobed appearance that resembles a cloverleaf. This severe cranial deformity often associates with increased intracranial pressure and neurological complications. Severe platyspondyly describes the flattening of the vertebral bodies throughout the spine, creating vertebrae that appear like pancakes rather than the normal rectangular building blocks. This spinal involvement contributes to the shortened trunk and can create additional neurological complications. The telephone receiver femurs provide another pathognomonic finding where the thigh bones develop a characteristic curved shape that resembles an old-fashioned telephone handset. This distinctive appearance on X-rays helps confirm the diagnosis and reflects the severe disruption of normal bone development. The respiratory insufficiency ties all these features together as the life-limiting complication. The combination of chest wall abnormalities, possible neurological involvement, and overall severity creates breathing difficulties that cannot be overcome with current medical interventions. The management approach for thanatophoric dysplasia requires a fundamental shift from curative to palliative care, recognizing that our role focuses on providing comfort and support rather than attempting to reverse the underlying condition. This represents one of the most challenging aspects of neonatal care, where your clinical expertise must blend with compassionate end-of-life care. Think of supportive care as encompassing all the measures we use to ensure the baby remains comfortable while addressing the family's emotional and spiritual needs. This might include pain management, assistance with breathing difficulties, feeding support, and maintaining normal body temperature. The goal shifts from fixing the problem to ensuring dignity and comfort during the baby's life. The importance of discussing prognosis early reflects the need to help families understand their situation and make informed decisions about their baby's care. This conversation requires exceptional sensitivity because you're helping parents process devastating news while providing them with the information they need to make choices about their child's care. Think of this as one of the most important conversations you'll ever have, requiring both clinical honesty and compassionate support. Comfort measures become the focus of your interventions, emphasizing anything that reduces suffering or provides solace to both the baby and family. This might include facilitating bonding opportunities, supporting breastfeeding if possible, enabling family presence, and coordinating with chaplaincy services or other support resources. Genetic confirmation through testing provides definitive diagnosis and enables accurate counseling about recurrence risks for future pregnancies. This information becomes crucial for family planning decisions and helps ensure appropriate prenatal care in subsequent pregnancies. Perhaps most importantly, recognizing that family support is critical acknowledges that your care extends beyond the affected baby to include parents, siblings, and extended family members who are all processing this tragic situation together. Osteogenesis imperfecta, commonly known as brittle bone disease, represents a group of genetic disorders that fundamentally alter how the body produces collagen type 1, the primary protein that gives bones their strength and flexibility. To help you understand this condition, think of collagen as the steel reinforcement bars in concrete. When these reinforcement bars are defective, the entire structure becomes weak and prone to breaking under normal stress. The underlying problem involves mutations in the genes responsible for producing collagen type 1, which serves as the scaffolding that gives bones their tensile strength. Picture normal bone as a composite material where calcium phosphate crystals provide hardness, while collagen fibers provide flexibility and resistance to fracture. When the collagen is abnormal, bones become brittle and break easily, even with minimal trauma. Understanding that multiple types exist helps you recognize the wide spectrum of severity this condition can present. Types 1 through 4 represent the main categories, with type 1 being the mildest and type 2 being the most severe. This classification system helps predict prognosis and guides treatment decisions, though the clinical presentation can vary significantly even within the same type. The wide severity spectrum means that some individuals live relatively normal lives with occasional fractures, while others face life-threatening complications from birth. In neonatal practice, you'll primarily encounter types 2 and 3, which represent the most severe forms that become apparent during the newborn period. Type 2 proves lethal in the perinatal period, while type 3 creates severe disability but allows survival to adulthood with appropriate management. OI type 2 represents the most severe form of osteogenesis imperfecta, creating such profound bone fragility that survival becomes impossible despite our best medical interventions. Understanding this condition requires recognizing how severely defective collagen affects every aspect of skeletal development, creating a clinical picture that's both distinctive and tragic. The presence of multiple fractures occurring in utero tells us that the bones are so fragile they cannot withstand even the normal movements and positioning that occur during fetal development. Think about how a baby normally moves and kicks within the womb. These natural movements, which should strengthen developing bones, instead cause fractures when the skeletal structure is this severely compromised. The beaded ribs create a characteristic radiographic appearance, where the ribs look like strings of beads, rather than smooth, continuous bones. This deformity occurs because the repeated fractures and healing attempts create irregular, bumpy contours along the rib surfaces. These rib abnormalities contribute significantly to the respiratory problems because they cannot provide adequate support for lung expansion. The soft skull develops because the collagen defect affects all bones, including those that normally protect the brain. When you examine these babies, their skulls feel unusually compressible, almost like touching a soft ball, rather than the firm structure you expect. The blue sclerae occur because the defective collagen makes the white part of the eyes thinner, allowing the underlying blood vessels to show through and create a blue tint. Death typically results from respiratory failure because the combination of rib abnormalities, chest wall instability, and possible neurological complications creates breathing difficulties that cannot be overcome with current medical technology. OI type 3 represents a severe form of osteogenesis imperfecta that allows survival but creates progressive deformities throughout life. Think of this condition as occupying the middle ground between the lethal type 2 and the milder forms, severe enough to cause significant disability, but not so severe as to prevent survival to adulthood. The presence of fractures at birth immediately alerts you to the severity of the condition, distinguishing it from milder forms that might not manifest until the child becomes mobile. These newborn fractures often occur during delivery or from the normal handling that occurs during routine care, demonstrating how extraordinarily fragile these bones are from the very beginning of life. The progressive bowing represents one of the most challenging aspects of this condition because the repeated fractures and abnormal healing create increasingly deformed bones over time. Picture how a piece of soft metal might bend and rebend until it becomes permanently misshapen. This same process affects the long bones in OI type 3, creating progressive deformities that worsen with each fracture cycle. The very short stature results from the combination of bone fragility, repeated fractures, and the progressive deformities that prevent normal growth. Think of this as a cumulative effect, where each complication adds to the overall impact on final height and proportion. The triangular face develops as part of the characteristic facial features associated with this condition, reflecting how the collagen defect affects facial bone development. Despite the severe physical manifestations, intellectual development remains completely normal, making this a condition that affects the body's structure while leaving cognitive function intact. The survival to adulthood distinguishes this from type 2, though the quality of life depends heavily on aggressive medical management and adaptive strategies. Managing babies with osteogenesis imperfecta requires fundamentally changing how you approach routine newborn care, because standard handling techniques can cause fractures in these extraordinarily fragile infants. Think of caring for these babies as being similar to handling delicate glass artwork. Every movement must be deliberate, gentle, and carefully planned to avoid causing damage. Gentle handling becomes the cornerstone of all care activities, requiring you to support the baby's body completely during any movement or positioning changes. Picture how you would carefully transport a fragile antique. You would support it from underneath, avoid sudden movements, and move slowly and deliberately. This same approach applies to babies with OI, where lifting, turning, or repositioning requires multiple hands and coordinated movements to distribute forces evenly. The requirement for support during transfers means that moving these babies from one location to another requires careful planning and often multiple people to ensure that all body parts remain supported throughout the movement. Think of this as creating a human stretcher system where the baby's weight is distributed across multiple support points rather than concentrated in areas that might create stress fractures. Pain management assumes critical importance because fractures cause significant discomfort, and these babies may experience pain from fractures that occur during routine care activities. Understanding that they may have multiple fractures in various stages of healing helps you appreciate why pain control becomes such an essential component of their care. Respiratory support may become necessary because rib fractures can interfere with normal breathing mechanics, while the overall fragility might limit the baby's ability to expand their chest adequately. The instruction to avoid blood pressure cuffs reflects how even the gentle pressure from routine monitoring equipment can cause fractures in these fragile bones, requiring alternative methods for vital sign assessment. The radiographic appearance of osteogenesis imperfecta creates distinctive patterns that help confirm the diagnosis while revealing the extent of skeletal involvement. Learning to recognize these imaging findings becomes essential because the X-ray changes often provide more definitive diagnostic information than the clinical examination alone. Multiple fractures in various stages of healing create the most characteristic finding, showing that this isn't a single traumatic event, but rather an ongoing process of bone fragility. Think of these X-rays as telling a story of repeated injury and healing attempts over time. You'll see some fractures that appear fresh with sharp edges and soft tissue swelling, while others show the smooth, rounded edges of healing bone with callus formation. Wormian bones represent small, irregularly shaped bone islands that appear within the skull sutures, creating a distinctive mosaic pattern. Picture how a jigsaw puzzle might look if someone had inserted extra pieces of various shapes. This same appearance occurs in the skull of babies with OI, where the abnormal collagen affects how the skull bones develop and fuse together. The generalized osteopenia appears as bones that look abnormally thin and translucent on X-rays, reflecting the overall weakness of the skeletal structure. Think of this as bones that appear ghost-like or washed out compared to the dense, white appearance of normal bones. The crumpled long bones seen in type 2 create a distinctive appearance where the bones look like they've been accordion folded or compressed, with irregular contours and abnormal shapes that reflect the severe deformities caused by repeated fractures. Beaded ribs show the characteristic bumpy, irregular appearance along the rib surfaces that results from repeated fractures and healing attempts, creating the distinctive pattern that helps distinguish OI from other conditions. The long-term management of osteogenesis imperfecta requires a comprehensive approach that addresses both the immediate challenges of bone fragility and the ongoing complications that develop throughout the child's growth and development. Think of this management strategy as creating a protective environment that minimizes fracture risk while maximizing functional potential. Bisphosphonate therapy represents a significant advance in OI treatment, using medications that help strengthen bones by altering bone metabolism. Picture these drugs as working like reinforcement materials that help make the defective bone structure somewhat more resistant to fracture. While they cannot cure the underlying collagen defect, they can significantly reduce fracture rates and improve bone density in many patients. Fracture prevention strategies become a way of life for these families, requiring modifications to the home environment, activity restrictions, and careful planning for all daily activities. Think of this as creating a comprehensive safety net that anticipates and prevents situations where fractures might occur, while still allowing the child to engage in age-appropriate activities. Orthotic support provides external reinforcement for weakened bones, functioning like external splints that help protect vulnerable areas during daily activities. These devices must be carefully designed to provide protection without creating pressure points that might cause fractures from the orthotic itself. Surgical rodding involves placing metal rods inside the long bones to provide internal support and prevent the progressive bowing that characterizes this condition. Picture this as creating internal scaffolding that helps maintain bone alignment even when fractures occur. The multidisciplinary team approach recognizes that optimal care requires coordination between orthopedic surgery, genetics, physical therapy, occupational therapy, and other specialists who can address the complex needs these children face throughout their development. When you encounter a baby with Arthrogryposis multiplex congenita, You're seeing the end result of decreased fetal movement that occurred during critical periods of joint and muscle development. To help you understand this condition, think about how normal joints develop. They require movement during fetal life to form properly, much like how a door hinge needs to move regularly to maintain its function. When this movement is restricted or absent, the joints become stuck in fixed positions. The name itself provides important clues about what you're observing. Arthrogryposis means curved joints, multiplex indicates multiple joints are affected, and congenita tells us the condition is present from birth. This terminology helps you understand that you're not looking at a single disease, but rather a clinical presentation that can result from over 150 different underlying causes. Here's a crucial concept that prevents diagnostic confusion. Arthrogryposis is not a single diagnosis, but rather a descriptive term for the pattern of multiple joint contractures present at birth. Think of it like fever. It's a sign that tells you something is wrong, but you need to investigate further to find the underlying cause. This understanding changes your entire approach because it means you're looking for the reason why fetal movement was decreased, rather than simply treating the obvious joint contractures. The key insight involves recognizing that anything that interferes with normal fetal movement during the critical period of joint development can potentially cause arthrogryposis. This could include neurological problems, muscle disorders, connective tissue abnormalities, or even mechanical constraints that prevent normal movement in the womb. Understanding the clinical features of arthrogryposis requires thinking about how the absence of normal fetal movement affects every aspect of limb development. Let me walk you through how each feature develops and why it creates the characteristic appearance you'll observe. The fixed joint positions occur because joints need movement during development. To form their normal range of motion, picture how a door hinge would become if it were never moved during the manufacturing process. It would lock in whatever position it was left in. The same principle applies to developing joints. When fetal movement is restricted, the joints become fixed in whatever position they were in when the movement stopped, creating contractures that can affect any joint in the body. Muscle atrophy or complete absence develops because muscles require nerve stimulation and movement to grow and develop normally. Think of this as the use it or lose it principle applied to fetal development. When the underlying condition prevents normal muscle function, the muscles either fail to develop properly or actually disappear entirely, creating the characteristic appearance of thin limbs with prominent bone outlines. The dimples over joints provide a distinctive clinical sign that helps you recognize arthrogryposis. These dimples form because the normal muscle bulk that would usually surround the joints is absent or severely reduced. Picture how your skin might dimple inward over a joint when there's no muscle tissue to fill out the normal contours. This same process creates the characteristic dimpling you observe in babies with arthrogryposis. The preservation of normal intelligence in most cases provides crucial information for family counseling. This tells you that while the condition affects the musculoskeletal system, it typically doesn't impact brain development, allowing these children to achieve normal cognitive milestones despite their physical challenges. Learning to recognize the different patterns of arthrogryposis involvement helps you understand the underlying pathophysiology and guides your approach to both diagnosis and treatment. Think of these patterns as providing clues about what type of problem caused the decreased fetal movement, much like how a detective uses evidence patterns to solve a case. The classic pattern involves all four limbs with symmetric involvement, creating the most extensive presentation where both arms and legs show multiple joint contractures. This pattern often suggests a generalized neuromuscular condition that affected the entire body during fetal development. Picture how a condition that affects the spinal cord or brain might create symmetric weakness throughout all limbs, leading to this comprehensive pattern. Lower limb predominant patterns occur more frequently and often suggest conditions that specifically affect the lower portion of the spinal cord or the nerves that supply the legs. Think about spinal cord abnormalities, like myelomeningocele, where the neurological damage primarily affects the lower extremities while leaving arm function relatively intact. Upper limb predominant patterns are less common, but can occur with conditions that specifically affect the nerves controlling arm function, such as severe brachial plexus injuries or certain muscle disorders that preferentially affect the shoulder and arm muscles. The distal pattern, affecting primarily the hands and feet, suggests conditions that specifically impact the nerves or muscles controlling fine motor function. This pattern often indicates a different type of underlying pathology than the more proximal patterns. Understanding how these patterns guide your search for the underlying etiology becomes crucial because different patterns suggest different diagnostic approaches. A baby with classic forelimb involvement needs comprehensive neurological evaluation, while one with isolated distal involvement might benefit from specific genetic testing for distal muscle disorders. The initial management of arthrogryposis focuses on working with the baby's existing anatomy while gradually encouraging improvement in joint mobility and function. Think of this approach as being similar to rehabilitating a door hinge that has become stuck. You need to work gently and persistently to restore movement without causing damage to the existing structures. Gentle stretching forms the foundation of treatment, but understanding the word gentle is crucial here. These babies have joints that have been fixed in position since fetal development, so attempting aggressive stretching can cause injury without providing benefit. Picture how you would carefully work with a rusty hinge. You'd apply steady, gentle pressure rather than forcing it, allowing the tissues to gradually adapt to new positions. The emphasis on early physical and occupational therapy cannot be overstated because the first months of life represent a critical window when tissues remain most adaptable to change. Think of infant tissues as being similar to warm clay that can be gradually molded into new shapes, while older tissues become more like hardened clay that resists change. This biological reality makes early intervention essential for achieving optimal outcomes. Serial casting provides a method for maintaining gentle, continuous pressure that encourages joint mobility while preventing the contractures from worsening. Picture how braces gradually straighten teeth by applying consistent, gentle force over time. Serial casting works on the same principle, using the natural healing and remodeling processes to gradually improve joint position. The concept of maintaining achieved range of motion becomes critical because these babies tend to lose mobility if it's not actively preserved. Think of this as the ongoing maintenance required for any mechanical system. Once you achieve improvement, you must continue working to prevent regression. The timing of surgery after 1 year reflects our understanding that conservative measures should be given adequate time to work before considering more aggressive interventions, while recognizing that surgical options can provide significant functional improvements when conservative treatment has reached its limits. Apert syndrome represents one of the most complex craniosynostosis syndromes you'll encounter, combining severe skull abnormalities with profound hand and foot deformities. To help you understand this condition, think of it as a developmental disruption that affects multiple organ systems simultaneously, creating a constellation of problems that require comprehensive, coordinated care from the moment of birth. The fundamental problem involves premature fusion of the coronal sutures, which normally allow the skull to expand as the brain grows during infancy. Picture how this early fusion creates a mechanical constraint that forces the growing brain to push the skull into abnormal shapes, creating the characteristic appearance of a tall, narrow forehead with prominent bulging of the eyes. This craniosynostosis doesn't just affect appearance, it can create dangerous increases in intracranial pressure that threaten brain development. The severe syndactyly that accompanies the craniosynostosis distinguishes Apert syndrome from other craniosynostosis conditions. Unlike simple syndactyly that might involve fusion of 2 adjacent fingers, Apert syndrome creates complex fusion involving multiple digits on both hands and feet. This combination of skull and limb abnormalities reflects the fact that both systems develop from related embryonic tissues during the same critical time frame. The incidence of 1 in 55,000 births makes this condition rare enough that many practitioners have limited experience with it, yet common enough that you'll likely encounter it during your career. Understanding that most cases result from sporadic mutations rather than inheritance helps explain why these babies are typically born to parents with no family history of the condition, making the diagnosis unexpected and requiring sensitive counseling about the complex medical needs ahead. The musculoskeletal features of Apert syndrome create some of the most distinctive and challenging abnormalities in all of pediatric medicine. Understanding these features requires thinking about how the same genetic defect that causes craniosynostosis also disrupts normal limb development, creating complex problems that will require multiple surgical interventions throughout childhood. The complex syndactyly affecting both hands and feet goes far beyond simple skin webbing between digits. Picture this as involving fusion of bones, joints, tendons, and soft tissues in patterns that create what we describe as mitten hands, because the fingers are so extensively fused that they resemble mittens more than individual digits. This fusion often involves all fingers, creating a single functional unit that severely limits the ability to grasp objects or perform fine motor tasks. The broad thumbs and great toes develop because the same developmental abnormalities that create the syndactyly also affect the size and shape of these important digits. Think of these as being disproportionately wide and short compared to normal thumbs and big toes, which compounds the functional limitations created by the syndactyly. The thumb abnormalities prove particularly problematic because thumb function is crucial for all grasping activities. Elbow ankylosis, when present, creates additional functional challenges by limiting the ability to bend the elbow joint. Picture how this restriction affects the child's ability to bring their hands to their mouth for feeding or to position their hands for functional activities. When combined with the hand abnormalities, this creates cumulative functional limitations that require creative adaptive strategies. The short stature reflects the systemic nature of the condition, where the same genetic abnormality affects growth throughout the skeleton. This generalized growth restriction means that children with Apert syndrome typically remain shorter than their peers throughout development, adding another layer of complexity to their medical management. The acute issues that can develop in babies with Apert syndrome require immediate recognition and intervention because they can become life-threatening if not addressed promptly. Understanding these complications helps you appreciate why Apert syndrome demands intensive medical management from birth and why early subspecialty consultation becomes essential for optimal outcomes. Airway compromise develops because the characteristic facial abnormalities create structural problems that interfere with normal breathing. The mid-face hypoplasia, combined with the abnormal skull shape, can create a narrow airway that becomes easily obstructed. Picture how the altered facial anatomy might create bottlenecks in the respiratory system, similar to how a partially blocked pipe restricts water flow. This breathing difficulty can become more pronounced when the baby is lying flat or during feeding, making constant vigilance necessary. Increased intracranial pressure represents the most dangerous complication because the prematurely fused skull cannot expand normally to accommodate the growing brain. Think of this as trying to fit an expanding balloon inside a rigid box. The pressure builds up and can damage the brain tissue if not relieved. The signs of increased pressure can be subtle in newborns, making careful monitoring essential for early detection. Feeding difficulties arise from multiple factors, including the airway problems, altered facial anatomy, and potential neurological involvement. The combination of breathing difficulties and abnormal oral anatomy can make coordinating sucking, swallowing, and breathing extremely challenging for these babies. Picture how you might struggle to eat while breathing through a narrow straw. This analogy helps you understand the mechanical challenges these babies face. Eye exposure problems develop because the abnormal skull shape can prevent the eyelids from closing completely, leaving the eyes vulnerable to drying and injury. The prominent eyes, combined with shallow eye sockets, create a situation where the protective mechanisms that normally keep eyes moist and safe become compromised. Managing babies with Apert syndrome requires a carefully orchestrated approach that prioritizes life-threatening complications while planning for the complex reconstructive journey ahead. Think of this management strategy as similar to conducting a symphony orchestra, where multiple specialists must work in perfect coordination to create optimal outcomes. Airway assessment becomes the absolute priority because breathing problems can develop rapidly and become life-threatening. This evaluation goes beyond simple observation to include systematic assessment of breathing patterns, oxygen saturation monitoring, and evaluation of feeding coordination. Picture how you would approach this assessment like a detective looking for clues, watching for signs of respiratory distress, listening for abnormal breathing sounds, and monitoring how the baby handles feeding challenges. Some babies may require immediate airway intervention, while others need careful monitoring with preparations for potential emergencies. Neurosurgery consultation must occur immediately because the craniosynostosis can create dangerous increases in intracranial pressure that require urgent surgical intervention. Think of this consultation as bringing in a specialist who can assess whether the skull abnormalities are creating immediate threats to brain development. The neurosurgeon will evaluate the pattern of suture fusion, measure head circumference trends, and assess for signs of increased pressure that might require emergency surgery. Hand surgery planning begins early because the complex syndactyly will require multiple staged procedures throughout childhood to optimize function. Picture this as developing a long-term reconstruction plan that considers not just the immediate abnormalities, but how the hands will need to function as the child grows and develops. The hand surgeon will assess which digits have the best potential for reconstruction and plan the sequence of procedures needed to achieve optimal function. Eye protection becomes essential because the prominent eyes and inadequate eyelid closure can lead to corneal damage and vision problems. This might involve artificial tears, protective eyewear, or even surgical procedures to improve eyelid function. Feeding support addresses the complex swallowing and breathing coordination problems that can make nutrition challenging for these babies. When you encounter Crouzon syndrome, you're observing a fascinating example of how genetic conditions can affect some organ systems while completely sparing others. This concept helps us understand why Crouzon syndrome represents a much more manageable condition than Apert syndrome, even though both involve craniosynostosis. Let me walk you through why this distinction matters so much clinically. Think about the challenges we discussed with Apert syndrome. The complex hand and foot abnormalities require multiple surgeries throughout childhood and create lifelong functional limitations. Now imagine the same craniosynostosis problems, but with completely normal hands and feet. This fundamental difference explains why children with Crouzon syndrome typically have much better functional outcomes and fewer overall medical complications. The maxillary hypoplasia creates the characteristic facial appearance where the middle portion of the face appears flattened or underdeveloped. Picture how this affects facial proportions. The upper jaw sits further back than normal, creating a distinctive profile that becomes more pronounced as the child grows. This underdevelopment can affect breathing, eating, and dental development. But these problems are generally more manageable than the complex limb abnormalities seen in Apert syndrome. The ocular proptosis, where the eyes appear to bulge forward, develops because the same bone abnormalities that affect the skull also create shallow eye sockets. Think of this as the eyes having less space to sit back in their normal position, making them appear more prominent. While this can create some of the same eye protection issues we discussed with Apert syndrome, the problems are typically less severe. Understanding that Crouzon syndrome carries a better prognosis than Apert syndrome helps you counsel families more optimistically while still acknowledging the real challenges that craniosynostosis creates. Let me guide you through the key features of Crouzon syndrome by building on what we've already learned about craniosynostosis conditions. This step-by-step approach will help you understand why some features create more problems than others. The preservation of normal hands and feet represents the most important prognostic factor in Crouzon syndrome. Think about how this changes everything about the child's future. They can feed themselves, write, play, and perform all the activities of daily living that require normal hand function. This single difference transforms the entire trajectory of the child's development and dramatically reduces the number of surgical procedures they'll need throughout childhood. Now let's examine the progressive craniosynostosis, which means that additional sutures continue to fuse abnormally over time. Picture this as an ongoing process rather than a single event. While some sutures may fuse early in infancy, others continue to close prematurely throughout childhood. This progressive nature explains why these children need ongoing monitoring and may require multiple cranial surgeries to prevent increased intracranial pressure. The cervical spine fusions might seem unrelated to the skull abnormalities, but they actually reflect the same developmental disruption affecting the entire axial skeleton. Think of the spine and skull as closely related structures that develop from similar embryonic tissues. When the genetic abnormality affects skull development, it often influences spinal development as well, creating the neck fusions we see in some patients. Here's where it gets interesting. Elbow ankylosis can occur in Crouzon syndrome despite the normal hand development. This teaches us that the genetic defect can affect some joints while sparing others, creating a complex pattern that requires individual assessment for each patient. The hydrocephalus risk emerges because the abnormal skull development can interfere with normal cerebrospinal fluid circulation, creating a buildup of fluid that increases intracranial pressure and threatens brain development. Let me walk you through campomelic dysplasia by starting with its name, which provides important clues about what we're observing. The term campomelic comes from Greek words meaning bent limb, and this tells us immediately that we're dealing with a condition where bones develop abnormal curvatures. Think of this as our first clue in understanding why this condition creates such distinctive clinical features. Now, here's where campomelic dysplasia becomes particularly complex. It affects not just skeletal development, but also sexual development in a fascinating way. When you encounter XY individuals with campomelic dysplasia, they often develop as phenotypic females despite having male chromosomes. This happens because the same gene that controls bone development also plays a crucial role in male sexual development. Picture how a single genetic defect can cascade through multiple developmental pathways, creating seemingly unrelated abnormalities that actually share a common molecular origin. The respiratory insufficiency represents the life-threatening aspect of this condition. Let me help you understand why this happens by thinking about the chest as a bellows system. Normal breathing requires ribs that can expand and contract rhythmically to create the pressure changes that move air in and out of the lungs. When campomelic dysplasia affects rib development, it creates a chest wall that cannot expand adequately, leading to breathing difficulties that often prove fatal. The poor prognosis reflects the combination of severe skeletal abnormalities and the respiratory complications. Understanding that SOX9 mutations cause this condition helps explain why such diverse systems are affected. This gene acts like a master switch, controlling multiple developmental pathways during embryonic formation. Let me guide you through the clinical features of campomelic dysplasia by showing you how each finding connects to the underlying developmental problem. This step-by-step approach will help you understand why these specific abnormalities cluster together and how they create the overall clinical picture. Starting with the anterior tibial bowing, picture how this creates the characteristic bent bone appearance that gives the condition its name. The shin bones curve forward in a distinctive pattern that becomes immediately recognizable once you understand what to look for. This bowing isn't just cosmetic, it affects the mechanics of walking and creates challenges for orthopedic management throughout the child's life. The short limbs develop because the same genetic defect that causes the bowing also interferes with normal longitudinal bone growth. Think of this as the bone development process being disrupted in two ways simultaneously. The bones don't grow to their normal length, and they curve abnormally as they develop. This combination creates the characteristic proportions you observe in these babies. Now, let's examine the small chest, which creates the most serious clinical problems. Picture how the abnormal rib development creates a thoracic cavity that's too small to accommodate normal lung expansion. This isn't just a matter of the chest appearing small, it's functionally inadequate for supporting the respiratory demands of a growing infant. The cleft palate adds another layer of complexity because it can compound the breathing and feeding difficulties these babies already face. The presence of only 11 pairs of ribs, instead of the normal 12, tells us that the developmental disruption affected the formation of the entire rib cage, not just individual bones. Understanding how these features work together helps you appreciate why campomelic dysplasia creates such profound challenges for survival and normal development. Let me introduce you to dystrophic dysplasia by explaining how it differs from the other skeletal conditions we've discussed, while showing you why its name provides important diagnostic clues. The term dystrophic means twisted, and this immediately tells us that we're looking at a condition where normal developmental processes become distorted in characteristic ways. Think of dystrophic dysplasia as occupying a different position on the spectrum of skeletal abnormalities compared to the lethal conditions we've examined. While conditions like Thanatophoric Dysplasia prove incompatible with life, dystrophic dysplasia creates significant challenges but allows survival to adulthood with appropriate management. This distinction fundamentally changes how we approach these families and what we can offer in terms of treatment and hope. The hitchhiker thumbs create one of the most distinctive features of this condition. Picture how these thumbs appear. They're positioned at an unusual angle that resembles the gesture someone might make when hitchhiking, with the thumb extended backward in an exaggerated position. This abnormal positioning reflects the underlying cartilage and connective tissue problems that affect joint development throughout the body. The cauliflower ears develop because the same connective tissue abnormalities that affect the skeleton also impact the cartilage that gives ears their normal shape. Think of this as the ear cartilage becoming inflamed and thickened, creating a bumpy, irregular appearance that resembles a cauliflower. This finding helps us understand that dystrophic dysplasia affects connective tissues throughout the body, not just the obvious skeletal abnormalities. The severe club feet and cervical kyphosis round out the clinical picture, showing us how this condition creates problems that span from the neck down to the feet, requiring comprehensive orthopedic management throughout childhood. Now that we understand the clinical features of dystrophic dysplasia, let me walk you through the management challenges these create, and why understanding these connections helps you provide better care. Think of this as learning how each anatomical abnormality translates into specific medical problems that require ongoing attention. The difficult airway represents our first major challenge, and understanding why this develops helps you prepare for it. The cervical spine abnormalities, combined with the connective tissue problems, can create structural changes that make routine procedures like intubation much more challenging than normal. Picture how the altered neck anatomy might change the usual landmarks and pathways that anesthesiologists rely on, making every procedure requiring airway management a potential challenge. The cervical spine instability creates an ongoing safety concern because the same connective tissue abnormalities that affect other joints also compromise the stability of the neck vertebrae. Think of this as having a structural weakness in one of the most critical joints in the body, the connection between the skull and spine. This instability means that even routine activities like positioning for procedures or playing normal childhood games can potentially create dangerous situations. Let me help you understand why multiple orthopedic procedures become necessary by thinking about the comprehensive nature of this condition. Unlike a single fracture that heals and causes no further problems, dystrophic dysplasia creates ongoing challenges that evolve as the child grows. The joint contractures, severe club feet, and progressive deformities each require specialized interventions, often multiple times throughout childhood. Here's the encouraging aspect. Despite these multiple challenges, dystrophic dysplasia is compatible with life. This means that with appropriate medical management, these children can survive to adulthood and often achieve meaningful functional independence, making the complex medical journey worthwhile for families willing to navigate it. Let me introduce you to a group of related conditions that share a common, life-threatening feature. They all create chest abnormalities that can severely compromise breathing. Understanding short rib thoracic dysplasias requires thinking about how the chest functions as a bellows system, where the ribs must expand and contract rhythmically to create the pressure changes that move air in and out of the lungs. To help you grasp why these conditions prove so dangerous, picture what happens when this bellows system becomes compromised. The narrow chest that characterizes these disorders creates a thoracic cavity that's simply too small to accommodate normal lung expansion. Think of trying to breathe while wearing a tight corset. The mechanical restriction prevents your lungs from expanding fully, creating the respiratory insufficiency that makes these conditions potentially lethal. The short horizontal ribs represent the anatomical foundation of this problem. Instead of developing the normal curved shape that creates adequate chest volume, these ribs grow in abnormally short, horizontal patterns that create a constricted chest wall. Imagine trying to build a barrel using staves that are too short. The resulting container would be narrow and inadequate for its intended purpose. While June syndrome and Ellis-Van Creveld syndrome represent the most commonly encountered forms, numerous other conditions share this basic pattern of thoracic restriction. What makes this group particularly challenging is that the limb involvement varies dramatically between different types. Some children have relatively normal arms and legs, but severe chest problems, while others show significant limb abnormalities alongside their respiratory issues. This variability means that each case requires individual assessment to understand the full scope of the condition and plan appropriate interventions. Now, let me walk you through spondyloepiphyseal dysplasia by breaking down its name, which actually provides a roadmap for understanding this condition. Spondylo refers to the spine, epiphyseal indicates the growth plates, and dysplasia means abnormal development. This terminology tells us immediately that we're dealing with a condition that primarily affects two critical components of the growing skeleton. Think about why this combination proves so significant clinically. The spine provides our central structural support, while the growth plates control how all our bones lengthen during childhood. When both systems are affected simultaneously, you get a condition that creates distinctive proportional changes and potentially serious complications that require ongoing medical management. The short trunk that characterizes this condition develops because the spinal abnormalities interfere with normal vertebral growth and development. Picture how this affects overall body proportions. While the arms and legs may grow relatively normally, the trunk remains shorter than expected, creating individuals who appear to have long limbs relative to their torso length. This disproportion becomes more apparent as the child grows and provides an important diagnostic clue. Here's where the condition becomes particularly concerning. The odontoid hypoplasia creates a potentially dangerous situation at the junction between the skull and spine. The odontoid process acts like a pivot point that allows your head to rotate, and when this structure is underdeveloped, it can create instability that threatens the spinal cord. Think of this as having a loose connection in the most critical joint in your body. The retinal detachment risk adds another layer of complexity because the same connective tissue abnormalities that affect the skeleton also impact the eyes. The C1-C2 instability represents the most immediate safety concern, requiring careful monitoring and activity restrictions throughout childhood to prevent catastrophic spinal cord injury. Let me introduce you to Larsen syndrome by helping you understand how it differs from the other skeletal conditions we've discussed. While most skeletal dysplasias primarily affect bone formation and growth, Larsen syndrome creates its distinctive features through problems with joint stability and connective tissue development. Think of Larsen syndrome as representing a different category of skeletal abnormalities. Instead of bones that are too short, too curved, or too fragile, this condition creates joints that are too loose and unstable. The multiple joint dislocations that characterize this condition occur because the connective tissues that normally hold joints together develop abnormally, allowing bones to slip out of their proper positions. Picture how this joint instability affects the baby's development and appearance. Unlike other conditions where you might see obvious bone deformities, Larsen syndrome often presents with joints that appear to be in the wrong positions. Shoulders, hips, knees, and other joints may be partially or completely dislocated, creating a clinical picture that can be quite dramatic when you first encounter it. The flat face provides another distinctive feature that helps you recognize this condition. Think of how the same connective tissue problems that affect the joints also influence facial development, creating a characteristic flattened appearance that differs from the facial features we see in other skeletal dysplasias. This facial appearance, combined with the joint problems, creates a recognizable pattern once you understand what to look for. The spatulate thumbs describe a distinctive thumb shape that appears flattened and broadened, resembling a spatula. This finding provides another diagnostic clue that helps distinguish Larsen syndrome from other conditions with joint problems. The cervical kyphosis creates the most serious medical concern because spinal instability in the neck region can threaten the spinal cord. Understanding that both dominant and recessive forms exist helps explain why some families have multiple affected members, while others have isolated cases, providing important information for genetic counseling and family planning discussions. Developing clinical suspicion for skeletal dysplasias requires training your eye to recognize patterns that suggest something more complex than typical newborn variations. Think of this recognition process as being similar to pattern recognition in any field. Once you understand what to look for, abnormal findings begin to stand out clearly against the background of normal variation. Disproportionate short stature provides your most important clue, but understanding what we mean by disproportionate becomes crucial. Unlike babies who are simply small overall, those with skeletal dysplasias show specific patterns where certain body segments are more affected than others. Picture how a baby with achondroplasia has a relatively normal-sized head and trunk, but dramatically shorten limbs, creating proportions that appear immediately different from simple, small for gestational age infants. Multiple fractures at birth should immediately trigger your suspicion for conditions like osteogenesis imperfecta. Remember that while single fractures can occur from birth trauma, multiple fractures suggest underlying bone fragility that requires comprehensive evaluation. Think of this as the difference between a single accident and a pattern that suggests systematic weakness. Abnormal skull shape encompasses both the premature suture fusion seen in Craniosynostosis syndromes and the characteristic head shapes associated with various skeletal dysplasias. Joint dislocations or contractures, particularly when they involve multiple joints or appear in unusual patterns, can indicate conditions like Larsen syndrome or Arthrogryposis. Family history provides crucial context because many skeletal dysplasias follow predictable inheritance patterns. However, remember that many cases represent new mutations, so the absence of family history doesn't rule out these conditions. When you suspect a skeletal dysplasia, your evaluation approach must be systematic and comprehensive because the pattern of involvement often provides more diagnostic information than any single finding. Think of this evaluation as creating a complete anatomical map that will guide specialists in making accurate diagnoses and treatment plans. The complete skeletal survey represents the foundation of your evaluation, but understanding what constitutes complete becomes essential. This involves much more than routine chest and extremity films. You need images that systematically examine every region of the skeleton. Include skull films to evaluate for craniosynostosis or other cranial abnormalities, complete spine imaging to assess for vertebral malformations, and pelvis films that can reveal characteristic pelvic changes associated with different conditions. Taking specific measurements during your evaluation provides objective data that proves invaluable for diagnosis and monitoring. These measurements include not just standard length and weight, but also the specialized anthropometric assessments we discussed earlier. Upper to lower segment ratios, head circumference, chest circumference, and limb measurements. Think of these numbers as creating a quantitative fingerprint that helps specialists distinguish between similar appearing conditions. Photography serves as an important adjunct to your clinical documentation because it captures subtle dysmorphic features that might be difficult to describe in words. Consider taking systematic photographs that document facial features, body proportions, and specific abnormalities from multiple angles. These images become particularly valuable when consulting with genetic specialists who may not be able to examine the baby directly. Saving DNA samples or tissue specimens provides crucial resources for genetic testing that may become available in the future. Even when current testing cannot provide definitive answers, preserved samples ensure that families can benefit from advancing diagnostic capabilities as they develop. Understanding when to involve genetics. Specialists requires recognizing that skeletal dysplasias represent complex genetic conditions that benefit from specialized expertise in both diagnosis and family counseling. Think of genetic consultation as bringing in experts who can navigate the complicated landscape of genetic testing, inheritance patterns, and family planning implications that these conditions create. All suspected skeletal dysplasias warrant genetic consultation because accurate diagnosis often requires specialized knowledge of the subtle differences between similar appearing conditions. While you might recognize that a baby has a skeletal dysplasia, distinguishing between conditions like different types of osteogenesis imperfecta or various short rib thoracic dysplasias requires the pattern recognition skills that genetic specialists develop through extensive experience with these rare conditions. The presence of multiple congenital anomalies suggests possible syndromic associations that extend beyond isolated skeletal problems. When you encounter a baby with both skeletal abnormalities and other system involvement, genetics consultation helps determine whether these findings represent separate problems or components of a single syndrome. This distinction fundamentally changes both the prognosis and the medical management approach. Lethal conditions require immediate genetic consultation because families facing these devastating diagnoses need specialized support and counseling that addresses the unique challenges of caring for a baby with a terminal condition. Genetics specialists can provide crucial information about what to expect, help families understand their options, and coordinate with other specialists to ensure comprehensive care. Recurrence risk counseling becomes essential for all families affected by skeletal dysplasias because these conditions often have significant implications for future pregnancies. Understanding inheritance patterns, discussing reproductive options, and providing information about prenatal diagnosis requires the specialized knowledge that genetics professionals bring to these complex situations. Let me consolidate the most critical concepts about skeletal dysplasias that will serve you well in clinical practice and represent high-yield information for your ongoing education. Think of these key points as essential knowledge that helps you provide excellent care while recognizing when to seek additional expertise. Achondroplasia management centers on monitoring for Foramen Magnum stenosis, which represents the most serious complication that can develop in these otherwise stable children. Remember that the characteristic hypotonia and delayed motor milestones in achondroplasia babies often reflect this underlying neurological compression rather than simple developmental delays. Understanding this connection helps you recognize when urgent neurosurgical evaluation becomes necessary. Osteogenesis imperfecta management requires two fundamental approaches that work together to optimize outcomes. Gentle handling prevents additional fractures while the child's bones remain extremely fragile, while bisphosphonate therapy provides the first effective medical treatment that can actually strengthen the abnormal bone structure. This combination of protective care and active treatment represents a significant advance in managing this challenging condition. Arthrogryposis responds best to early, aggressive therapy because the joint contractures become increasingly resistant to treatment as the child grows. Think of this as a time-sensitive condition where the window for optimal improvement closes gradually, making immediate referral to specialized therapy services essential for achieving the best possible functional outcomes. Thanatophoric Dysplasia represents a lethal condition where your primary role involves providing compassionate support to families facing an unimaginable tragedy. Understanding that no curative treatment exists helps you focus your efforts on comfort care and emotional support rather than pursuing interventions that cannot change the ultimate outcome. Throughout all these conditions, thorough documentation proves essential because accurate diagnosis often requires subspecialist review of detailed clinical information, imaging studies, and genetic testing results that may not be immediately available. As we conclude our comprehensive journey through musculoskeletal development and birth injuries, let me help you synthesize the major themes that will guide your clinical practice and serve as the foundation for excellent patient care. Think of these concepts as the essential framework that ties together everything we've learned about how the musculoskeletal system develops and what happens when that development goes awry. The power of embryology to explain malformations represents perhaps our most important conceptual insight. When you understand that the 4th through 6th weeks of embryonic development establish the foundation for the entire musculoskeletal system, you begin to appreciate why disruptions during this narrow window create such profound and lasting consequences. This knowledge transforms your approach from simply describing what you observe to understanding why these abnormalities developed and how they're likely to behave over time. Early recognition consistently improves outcomes across virtually every condition we've discussed. Whether you're identifying developmental dysplasia of the hip in a newborn, recognizing the early signs of osteogenesis imperfecta, or detecting brachial plexus injuries before complications develop, your ability to spot these conditions promptly often determines whether families face relatively straightforward treatments or complex long-term management challenges. The systematic evaluation approach ensures that you don't miss important findings or associated abnormalities. Remember how we emphasized looking beyond the obvious abnormality to search for the patterns that help distinguish between similar conditions and identify the associated anomalies that might otherwise be overlooked. Understanding that many conditions have associations fundamentally changes how you practice medicine, moving you from isolated problem-solving to comprehensive care that anticipates and addresses the full spectrum of each condition's manifestations. Finally, recognizing that multidisciplinary approaches produce optimal outcomes helps you coordinate the specialized care these complex conditions require. Let me leave you with the most essential clinical pearls that represent both high-yield certification material and the knowledge that will serve you best in providing excellent patient care. These concepts appear repeatedly on examinations because they reflect the fundamental principles that guide optimal management of musculoskeletal conditions. DDH screening represents a universal mandate because early detection allows for simple, effective treatment, while missed cases often require complex surgical reconstruction with less predictable outcomes. Remember that this screening involves not just the clinical examination techniques we discussed, but also understanding risk factors and knowing when to pursue imaging studies. The key insight involves recognizing that even babies without obvious risk factors can develop DDH, making systematic screening essential for all newborns. The Ponseti method for clubfoot has revolutionized treatment by transforming a condition that previously required extensive surgery into one managed primarily through conservative approaches with excellent outcomes. Understanding this method as the gold standard helps you counsel families appropriately and ensures timely referral for optimal results. Erb's palsy recovery statistics provide crucial prognostic information that helps you support families through the anxiety of seeing their baby's arm weakness. The 90% recovery rate for this most common form of brachial plexus injury offers genuine hope, while understanding the prognostic indicators helps you recognize when more aggressive intervention might be necessary. Osteogenesis Imperfecta diagnosis hinges on recognizing that multiple fractures at birth represent a red flag requiring immediate evaluation for underlying bone fragility disorders. This pattern recognition prevents the tragic misdiagnosis of child abuse while ensuring that affected babies receive appropriate gentle handling and medical management. Finally, the mandate to check kidneys with all spine defects reflects the consistent association between axial skeletal abnormalities and genitourinary anomalies, making renal screening an essential component of comprehensive care for any baby with spinal abnormalities. An infant is noted to have asymmetric gluteal folds and limited hip abduction on physical examination. The NNP's next appropriate action should be to order a hip ultrasound and refer to orthopedics. Perform the Barlow and Ortolani maneuvers. Wait until the 2-month well check to reassess the findings. The correct choice is perform the Barlow and Ortolani maneuvers. This question is testing your knowledge of the appropriate initial assessment for suspected developmental dysplasia of the hip, DDH. Performing the Barlow and Ortolani maneuvers is correct because these are the standard initial clinical tests for hip instability and should be performed immediately when DDH is suspected. The other options are incorrect because ordering a hip ultrasound prematurely before performing a complete clinical examination skips an essential diagnostic step, and waiting until the 2-month check is inappropriate since early intervention for DDH leads to better outcomes. A term newborn presents with an arm held in adduction and internal rotation, with the elbow extended and the wrist flexed. The grasp reflex is intact, but the Moro reflex is asymmetric. The most likely diagnosis is complete brachial plexus injury. Erb's palsy, upper brachial plexus injury. Klumpke's palsy, lower brachial plexus injury. The correct choice is Erb's palsy, upper brachial plexus injury. This question is testing your ability to identify the specific type of brachial plexus injury based on clinical presentation. Erb's palsy is correct because the classic waiter's tip position, arm adducted and internally rotated, elbow extended, wrist flexed, with intact grasp reflex and asymmetric Moro reflex is pathognomonic for upper brachial plexus, C5-C6 injury. Complete brachial plexus injury is incorrect because grasp would be affected. Klumpke's palsy is incorrect because it primarily affects the hand and wrist with normal shoulder function, presenting with absent grasp reflex, but normal shoulder positioning. A neonate has a foot deformity characterized by plantar flexion, inward heel position, and forefoot adduction that cannot be passively corrected to midline. The appropriate diagnosis is clubfoot, talipes equinovarus. Metatarsus adductus, positional foot deformity. The correct choice is clubfoot, talipes equinovarus. This question is testing your ability to differentiate between foot deformities based on clinical characteristics and passive correctability. Clubfoot is correct because the combination of plantar flexion, inward heel position, varus, forefoot adduction, and inability to passively correct to midline are classic features of true talipes equinovarus. Metatarsus adductus is incorrect because it presents with forefoot adduction, but normal ankle movement and can be passively positioned midline. Positional foot deformity is incorrect because, by definition, positional deformities can be passively corrected. The NNP notes an infant presents with head tilted to the right side, chin rotated to the left, and a palpable mass in the right sternocleidomastoid muscle. The most appropriate documentation of this finding is congenital muscular dystrophy, positional head preference, torticollis? The correct choice is torticollis. This question is testing your ability to recognize the clinical presentation of torticollis and distinguish it from other causes of abnormal head positioning. Torticollis is correct because the classic presentation includes head tilting toward the affected side, chin rotation to the opposite side, and a palpable mass or tightening in the sternocleidomastoid muscle. Congenital muscular dystrophy is incorrect because it presents with generalized hypotonia rather than focal neck muscle findings. Positional head preference is incorrect because it doesn't typically include a palpable mass in the sternocleidomastoid muscle. During examination of a newborn following a difficult delivery with shoulder dystocia, the NNP notes decreased arm movement, asymmetric Moro reflex, and crepitus on palpation of the right upper chest. The most likely diagnosis is clavicular fracture, humeral fracture, thoracic spine injury. The correct choice is clavicular fracture. This question is testing your knowledge of birth-related fractures and their clinical presentations. Clavicular fracture is correct because it's the most common neonatal fracture, especially following shoulder dystocia, and presents with the classic triad of decreased arm movement, asymmetric Moro reflex, and palpable crepitus over the clavicle. Humeral fracture is incorrect because crepitus would be felt over the humerus rather than the upper chest. Thoracic spine injury is incorrect because it's extremely rare in neonates and would present with more significant neurological findings.